I think it was a really interesting case she presented. I was happy to see that they repeated the fish analysis, so that I think is an important practice to do after a significant period of time has gone by. But here the major question, I think, is why this favorable risk patient developed progression of disease, and I'm calling this clinical resistance to a BTK inhibitor. But I think the intent of the workup was to try to document molecular resistance. I was wondering if you can speak to that and tell us a little bit about, what we might find in the setting of progression from a molecular perspective for patients who are treated with ibrutinib.
Sure. With patients that have been treated with ibrutinib, you can definitely find resistance within the BTK gene itself. Ibrutinib, when it normally binds, it actually binds within this ATP binding pocket to an exposed cysteine. You develop mutations that confer resistance, which actually change the cysteine to a different amino acid, and therefore the ibrutinib can no longer bind. That's one mechanism. Also, what you can find is mutations further down in the pathway, specifically in phospholipase C gamma 2. So sequencing of both of these genes is pretty much essential to document that you have resistance inherent to those.
I also think it's interesting that it was done in the context of progression. I'm curious from your practice, A, do you have the ability to do this type of testing? And then B, do you do it in setting of progression, or is there any value into doing it earlier on prior to clinical progression?
So that's a very important question. In our lab, we do not have the ability to do this particular testing. We can do it on a research basis, but we do not have a CLIA certified lab that can give us a result that can go into the patient's clinical record. And so we do use outside vendors where we get this testing done. There is data to suggest that in many patients who've been on ibrutinib as a single agent for many years, these resistance mutations actually develop early on before clinical relapse occurs. And so in the data that were presented, it appears that anywhere from a median of 9 to 12 months prior to clinical relapse. Although we do sequence some of our high-risk patients, particularly patients who have deletion 17p or maybe a TP53 mutation, to look for early evidence of relapse. Here is a prime example of a patient who did not meet any of the quote-unquote high-risk criteria, yet developed clinical relapse.
Although I guess we only saw the NGS performed
after the
fact, so we don't know if it was present.
That is true. I think the other thing to point out that is important is that when a patient who has been on ibrutinib for, and I couldn't tell how long this patient was on, maybe for a year or two, and has progressive disease, I think it's important to make sure that this patient has not developed a Richter's transformation. And I'm assuming that was thought of, and they did an LDH and potentially did a lymph node biopsy to make sure that there was no Richter's transformation. And had imaging as well, because again, data suggests that if a patient has early progression of disease on ibrutinib, particularly in the first 12 months, it's more likely to be a Richter's transformation as opposed to true CLL progression.